Welcome back to the deep dive. I have to admit, when I first saw this week's topic, I had a very specific image in my head. You know, vanity, celebrity culture, maybe a little nip and tuck in Beverly Hills.
Sure, that's what most people think of.
But then I started reading the stack of papers you sent over, especially those clinical guidelines from Dr. Hesham Saleh and Dr. Dagani, and I realized I was just completely wrong. This isn't about vanity at all. It's about architecture.
Oh, it's absolutely structural engineering. That is the only way to look at it.
It's high-stakes engineering where the building materials are bone and cartilage, and the building is, well, it's the absolute center of a person's identity.
Exactly.
So today, we're unpacking three really distinct sources. We have a clinical case of a young man with a deviated septum. Sounds incredibly painful. Then a severe case of a saddle nose deformity that, it required using rib cartilage to rebuild a face.
Yeah, heavy-duty stuff.
And then those expert assessment guidelines I mentioned.
And the common thread through all of them is that rhinoplasty, the quote-unquote nose job, is arguably the most difficult operation in facial plastic surgery. Not just technically, but psychologically.
That's exactly where I want to start, the psychology. Because the sources make this incredible point that the surgery doesn't start in the operating room.
No, not at all.
It starts in the consultation room. And according to Dr. Saleh's text, you can perform a technically perfect surgery. Straighten the bone, refine the tip, perfect the airflow, and it can still be a complete and total failure.
Right. Because the result doesn't actually live on the patient's face. It lives in the patient's mind. And if their perception doesn't match the surgical outcome, you failed. That's why that assessment phase is described as being the gatekeeper.
The surgeon has to decide, is this person safe to operate on?
Exactly.
The text actually creates these archetypes for patients. They have the green light patient, who they call Sylvia, which I found kind of funny. Get her name.
Well, it helps to visualize the ideal, right? Sylvia is the candidate who's grounded. She's intelligent, she listens, but most importantly, she has a specific objective deformity she wants fixed.
So she sees a bump, not a ruined life.
Precisely. She looks in the mirror and sees a bump on the bridge of her nose. She understands that fixing the nose is going to fix the nose, not her marriage or her career.
Okay, so Sylvia's the easy part. But then we get to the red flags. And this is where I actually found myself, pushing back against the text a little. I wanted to get your take on this.
Oh, really? How so?
Well, one of the big red flags they list is the diagram patient. The source describes this person who comes in with drawings or like Photoshop mock-ups all measured to the millimeter. They know exactly what they want. Now, in any other field, if I'm hiring an architect, that's a dream client. They're prepared. Why is this a red flag here?
It's a red flag because it implies a complete misunderstanding of the material. If you're building a kitchen, you're working with granite and wood.
Right. Predictable stuff.
Totally predictable. If you cut wood to 10 inches, it stays 10 inches. Human tissue is, it's alive, it's reactive, it swells, it scars, it contracts.
So the patient brings a blueprint, but the body just refuses to follow it.
Exactly. If a patient says, I want the tip to be exactly 14 millimeters from the facial plane, they're setting up this pass-fail scenario that the surgeon is almost guaranteed to fail, not from a lack of skill, but because of biology. The source warns that these patients are just too rigid.
Rigidity leads to dissatisfaction.
You've got it.
Yeah.
You want a patient who understands the concept of the improvement, not the math of it.
That makes so much sense. There was another one that felt like a trap. The overly flattering patient, the one who says, you're a magician or you're the only person in the world who can fix me.
You run. That is what every experienced surgeon thinks when they hear that. It's a sign of narcissism or emotional instability. Because that dynamic flips instantly. If you accept the title of magician, you're promising magic. And surgery isn't magic, it's medicine. The moment there's a tiny imperfection, and there's always a tiny imperfection, that patient turns on you. You go from God to devil in a heartbeat.
The ultimate red flag, though, the one listed as an absolute contraindication, meaning do not operate, period, is BDD, body dysmorphic disorder.
This is such a critical distinction. BDD is a psychiatric condition where a patient focuses intensely on a perceived defect that is either minor or completely non-existent to anyone else.
But if they're suffering so much, why not just fix the nose? Wouldn't that help?
No, and the sources are very, very firm on this. The problem isn't the nose. The problem is the internal image of the nose. If you operate on a BDD patient, you're just validating their delusion.
You're confirming there was something wrong.
Yes, and then after surgery, they just shift their fixation. They'll say, okay, the bump is gone, but now my nostrils are uneven, or they'll obsess about their chin. You just cannot cut away a psychological problem with a scalpel.
So let's say we've screened the patient, we found her Sylvia. Now let's get into the actual engineering. I want to look at case study A in our stack, the deviated septum case.
This is a really classic example of functional problems colliding with aesthetic ones.
So we have a young male patient. He's healthy, but he just can't breathe. The diagnosis is rhinoscoliosis type 3, and the description of his nose is a reverse C-shaped deformity. Help me picture that. Is his nose literally shaped like a C?
Well, think of the nose like a tent held up by a central pole. That pole is the septum. In this case, the bony part at the very top, the bridge between the eyes, is straight, but the cartilage, the flexible part of the pole further down, has buckled. It curves out to one side and then hooks back. So if you're looking at it from the front, the nose just looks twisted.
And because the pole is twisted, the tent is collapsing.
That's it, exactly. The source mentions a positive Cottle's test.
I looked this up. This is where the doctor pulls on the patient's cheek, right?
Yes. You put your finger on the cheek right next to the nose and just pull the skin outward. It manually opens up the internal nasal valve. If the patient takes a breath and goes, oh, wow, I can breathe so much better, it means the structure itself is too weak to hold the airway open. It's collapsing.
Wow. There's another phrase in his diagnosis that I loved, compensatory hypertrophy. It sounds like something a bodybuilder does, but in the nose.
It's the body trying to fix a problem and making it worse.
Yeah.
Nature abhors a vacuum. In this patient, the septum is deviated to the left, blocking that left nostril. So the right nostril is wide open, too open.
So the body tries to fill it in?
Yep. The turbinate, which is this sort of radiator-like structure on the sidewall of the nose, it swells up. It hypertrophies to fill that empty space on the right. So the patient is blocked on the left by crooked bone and blocked on the right by his own swollen tissue.
He's checkmated his own airway?
Precisely.
So how do they fix it? The surgical plan lists an open approach septorrhinoplasty. I know open means they make an incision on the columella, that little strip of skin between the nostrils, and then they lift the skin up. But once they're inside, the tools sound pretty intense. Osteotomies.
That's really just a fancy word for controlled bone fracturing. To straighten the bony pyramid at the top, they essentially have to use a chisel to break the nasal bone so they can mobilize them and reset them straight.
So they're using a hammer and chisel.
It's not delicate work, no. But then, to keep it all open, they use spreader grafts. This was the part that felt most like carpentry to me. It is carpentry. Remember the Cottle test? The collapsing valve? A spreader graft is a little rectangular strip of cartilage, usually harvested from the crooked septum they just removed.
Okay.
They take that strip and they wedge it between the septum and the upper side wall cartilage.
Like a shim, like you'd put in a door frame to keep it from sticking.
Exactly like a shim. It physically pushes the side walls outward. This does two things. It keeps the airway open so he can breathe, and aesthetically, it restores the dorsal aesthetic lines. It makes the bridge of the nose look straight and strong instead of pinched.
And the source mentions they're aiming for very specific numbers here. They talk about goods ratio. The patient started at 0.52, and they wanted to get him to 0.55 or 0.6.
Right, that refers to tip projection. So how far the nose sticks out from the face relative to its length. This patient had a bit of a squashed tip, so they're not just straightening the wall, they're using a strut to sort of jack up the tip. It really is geometry.
It's amazing. But okay, case A is a repair job. Case study B, this felt more like a disaster
The
response.
saddle nose, yes.
The description is visceral. A depressed concave dorsum and a drooping underprojected tip.
Imagine a boxer's nose that's been flattened, or a ski slope. The bridge of the nose has just collapsed inward.
And the cause here is a septal perforation, a hole in the septum.
Yeah, the support pillar didn't just bend, it rotted away or snapped. There's a hole right through the cartilage. And without that support, the whole skin envelope just sinks into the face.
The source lists the potential causes, and it's a rough list. Trauma, bad previous surgery, autoimmune diseases, and then the big one, cocaine.
Right, and notice how the source is extremely strict here. Active cocaine use is listed as an absolute contraindication.
Why is that specifically absolute? I mean, obviously drug use is bad for your health, but is there a specific surgical reason?
Oh, absolutely. It's physiological. Cocaine is a potent vasoconstrictor. It clamps down on blood vessels. The lining of the nose needs that blood supply to live. If you're trying to reconstruct a nose, you're putting in grafts that need to establish a new blood supply to survive.
Ah, so if the patient uses cocaine.
They're shutting off the fuel. The tissue will die. The new nose will turn black and necrotic.
That is a terrifying image. So you literally cannot build on a foundation that's being chemically destroyed.
Correct. You have to wait until they're clean for a long, long time, or you simply cannot operate.
But let's assume this patient is clean. The nose is flat. The septum is gone. How do you rebuild a bridge when you have no lumber left?
You have to import building materials from elsewhere in the body. Heavy-duty materials.
And according to the text, the gold standard is ribs.
Costal cartilage.
Yes. They cut into the chest.
They do. They make a small incision on the chest wall and harvest a section of the 6th or 7th rib cartilage. It's perfect because it's abundant, it's strong, and you can carve it. The surgeon basically whittles a new structural beam from the rib to replace the bridge of the nose.
Wow.
It's often the only thing strong enough to lift that heavy skin envelope back up.
And what about the hole? The perforation inside?
That's the other challenge. You can't just leave a hole between the nostrils. The text mentions using temporalis fascia to patch it.
Which comes from where?
The side of the head, near the temple. It's a very tough, fibrous sheet of tissue. They harvest a patch of that and slide it in between the lining layers of the septum to close the hole.
So for this one nose job, the surgeon is harvesting bone from the rib, tissue from the temple, and then rebuilding the center of the face.
It really reframes the term plastic surgery, doesn't it? This is reconstructive surgery in its purest form.
It really does. I want to zoom out a bit to the general anatomy principles in Dr. Saleh's summary. Because even if you do all this amazing structural work, the ribs, the beams, the shims, the outcome still depends on the wrapper, the skin.
The soft tissue envelope. It's arguably the most uncontrollable variable in the whole surgery.
I always just assume skin is skin, but the text says thick skin is difficult. That felt totally counterintuitive to me. I'd have thought thick skin is good, it hides mistakes.
It hides mistakes, yes, but it also hides the art. Think of it like this. Imagine you carve a beautiful, detailed statue out of marble. If you drape a silk sheet over it, you can still see all the details, the curves. That's thin skin.
Okay.
Now imagine throwing a heavy wool blanket over that same statue. You lose all the definition. All that sharp carving just looks like a round lump. That's thick skin. So the source warns that patients with thick, sebaceous skin have to be told very clearly. You will never have a tiny, defined, chiseled tip. The skin simply won't drape that tightly.
So the patient might blame the surgeon for a bulbous nose, but it's really just their own biology.
Exactly. And the surgeon has to manage that expectation before they ever pick up a scalpel.
The other anatomical factor that surprised me was the chin. I did not expect the document about noses to talk so much about the jawline.
It's all about context. The nose doesn't exist in a vacuum. The nasolabial angle and chin projection define the whole profile.
And the text mentions that a weak, receding chin creates an optical illusion that makes the nose look massive.
Oh, we see this all the time. A patient comes in wanting a huge reduction in their nose.
Yeah.
They think their nose is giant.
Yeah.
But if you actually measure the geometry, their nose is normal. Their chin is just too far back.
So if you cut the nose to match the chin,
You ruin the face. You get this convex, sort of bird-like profile. Sometimes, the best rhinoplasty is actually a chin implant. You bring the chin forward, and suddenly, the nose looks proportional without even touching it that much.
it's all about balance.
The source emphasizes checking the facial thirds, the forehead, the nose, and the chin. They have to balance.
There was one final reality check in the source that I think is important for anyone listening who might be looking in the mirror right now. The myth of symmetry.
Ah, yes.
The source explicitly warns surgeons to manage the expectation of perfect straightness. It says it's basically impossible.
Because the foundation isn't straight. The human face is naturally asymmetrical. One eye is a little higher, one cheekbone is flatter. If you build a geometrically perfect ruler-straight nose on a crooked face, the nose will actually look crooked.
You would highlight the asymmetry of everything else.
Right, so you have to build a balanced nose, not a straight one. And honestly, tissue heals unpredictably. Scar tissue pulls. Cartilage can warp slightly. The goal, as the text says, is to create the illusion of symmetry.
Sisters, not twins.
That applies to nostrils just as much as eyebrows.
So let's look at the journey we've taken. We started with psychological screening, weeding out the BDD cases to find the Sylvius. We went through the mechanics of a deviated septum with its spreader grafts and caudal tests. Then the heavy lifting of the saddle nose, rebuilding a collapse with ribs and fascia.
And we realized that skin thickness and chin position dictate the outcome just as much as the surgery itself. It's a game of millimeters.
The source material did briefly touch on where the field is going. Did you catch the note on preservation rhinoplasty?
I did. It's a really exciting shift in philosophy. For 100 years, rhinoplasty was reductive. You chisel the hump off, cut the cartilage out, make it smaller by taking things away.
And preservation rhinoplasty is different.
It's about keeping the structure intact. So instead of cutting the roof off the house to lower it, you essentially remove a strip of the foundation and push down the whole house.
So you preserve the natural lines of the bridge.
Exactly. You preserve ligaments, skin attachment, blood supply. It's less traumatic, and the results can look more natural.
And when you combine that with the 3D planning that was mentioned, printing models of the skull beforehand, it seems like the engineering side is only getting stronger.
It's all about making it more predictable. That's the ultimate goal.
You know, reading all this, I'm left with this sort of philosophical question. You usually handle the deep thought, so I'm teeing you up here. The sources show that the line between a medical necessity like breathing and a cosmetic desire like looking good is incredibly blurry. The deviated septum guy couldn't breathe, but they also fixed his aesthetic lines. The saddle nose guy had a total collapse, but the fix was all about restoring his profile. It raises an important question about identity, doesn't it?
It does. You say the eyes are the window to the soul, but the nose is the anchor of the face. It's the literal center. When you change it, you aren't just changing airflow. You are changing the face that person has seen in the mirror their entire life.
That brings us right back to Sylvia. The surgery is a success only if she recognizes herself in the mirror afterwards.
Precisely. If you fix the breathing, but the patient looks in the mirror and sees a stranger, is that a success? The source material really suggests that surgery on the nose is, in many ways, surgery on the patient's identity. And that's why the surgeon has to be a psychologist first and a carpenter second.
That is something to think about. Well, I hope everyone listening has a newfound appreciation for their own dorsal aesthetic lines and their structural integrity next time they look in the mirror.
And maybe give your septum a little thanks for staying upright.
Definitely. Thanks for diving in with us. We'll catch you on the next deep dive.